Welcome to this peer voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/cfh. This program has been supported by an independent educational grant from Gilead Sciences Incorporated.
Dear friends, dear colleagues, hello. My name is Javier Cortés. I am a breast cancer medical oncologist working in IOB Madrid and in the International Breast Cancer Center in Barcelona in Spain. Very welcome to this peer voice activity where we will go over the recent developments on TROP2 antibody drug conjugates in advanced breast cancer, basically in triple negative breast cancer and HR positive HER2 negative BC. It is true that we have had important advances in both triple negative breast cancer and HR positive metastatic breast cancer, but these diseases continue to be an unmet needs. In this presentation, we will review briefly the clinical burden and the emerging evidence which supports the earlier evaluation of anti-TROP2 antibody drug conjugates currently used in later line settings. In brief, metastatic triple negative breast cancer is basically the most unmet need we have to date in breast cancer. The overall survival after first line is in the range of a year or so, and this disease is between 15 to 20% of all patients with metastatic breast cancer. So we need more and better drugs, more and better agents, more and better strategies as well. Something similar happens in the HR positive HER2 negative field, which accounts 70% of all breast cancers. After targeted therapy with CDK4 and 6 inhibitors and endocrine therapy, and once the tumors are clearly resistant to endocrine treatment, the median overall survival is poor, in the range of 2 to 3 years at best. And after first line, second line or beyond, the median overall survival is even much worse, with median overall survival rarely exceeding 2 years. So clearly, again, we need more and better drugs, more and better strategies. It is true that we have treatment options today in the late line setting with anti-TROP2 antibody drug conjugates, which have shown to improve survival. We have sacituzumab govitecan, and based on the ASCENT study, in second line or beyond, patients with triple negative breast cancer, SG improved not only progression-free survival and overall response rate, but also overall survival over physician choice, over chemotherapy. And this is one of the clear preferred options and maybe the standard of care today. Also in the ER positive, SG was or demonstrated to improve survival and progression-free survival thanks to the TROPiCS-02 study over chemotherapy. We have a second antibody drug conjugate, Dato-DXd deruxtecan, which also has shown an improvement in progression-free survival, but unfortunately not an improvement in overall survival in the TROPION-Breast01 study in second, third line against chemotherapy. So two antibody drug conjugates which improves progression-free survival, SG also overall survival. So would it be possible to move these drugs into the earlier lines to try to increase the activity before these patients might develop resistances? And that's something that we have been explored in the triple negative breast cancer with the ASCENT-03 and the TROPION-Breast02. In brief, ASCENT-03 is a randomized phase 3 study which explored SG compared with chemotherapy in PD-L1 negative or patients with PD-L1 positive, but they were not candidate to use immune checkpoint inhibitors. Patients were randomized against chemotherapy, paclitaxel, nab-paclitaxel, or carbogem. The primary objective was progression-free survival, and patients were able to cross to SG in the control arm if we observed centrally confirmed progressive disease. And we have a beautiful improvement in progression-free survival with a nice hazard ratio of 0.62. and the median progression-free survival moves from more or less 6.9 months to over 9.7 months. Nice improvement in PFS. And also the duration of response was much better, from 7.2 months to 12.2 months from chemotherapy or SG, respectively. We have a second study, TROP2 with another antibody-drug conjugate against TROP2, Dato-DXd. Similar study design, but with three key differences. The first one, datopotamab was compared with chemotherapy single agent. No carbogem was allowed. Second, two primary endpoints, progression-free survival and overall survival. And very importantly, patients were not offered second-line anti-TROP2 antibody-drug conjugate after progressive disease. So crossover was not allowed in this study. Primary endpoint, progression-free survival, has a ratio of 0.57, very similar to ASCENT-03, but also an improvement here in overall survival. It's important to remark that in the subgroup analysis in the Western population, the overall survival was identical between datopotamab deruxtecan and chemotherapy, maybe which reflects the crossover to SG beyond progression. Also, SG was explored in the first-line setting after patients received and were clearly resistant to endocrine therapy, to SG or chemotherapy, capecitabine, paclitaxel, or nab-paclitaxel. The primary endpoint was progression-free survival, and there was a trend to increase PFS, but this was not statistically significant. There was an interestingly numerical advance in overall survival, but these data were very immature. So please now answer the following challenge question. As we all know, there are about 30 to 40% of patients with metastatic triple-negative breast cancer which or whose tumors do express PD-L1, and the standard of care has been classically chemotherapy plus pembrolizumab. Would it be possible to optimize this strategy using antibody-drug conjugates against TROP2? And this is the purpose of the ASCENT-04 study. Basically, randomized phase 3, sacituzumab govitecan plus pembrolizumab or chemo plus pembro in patients who were candidate to pembrolizumab. So basically, triple-negative breast cancer and PD-L1 positive according to the CPS score 10 or more. Primary endpoint was progression-free survival by BCAR, and importantly, also patients were allowed to cross to sacituzumab govitecan after progression in the control arm. Primary endpoint was met. The hazard ratio was clearly achieved. Median PFS also was very nicely improved from 7.8 months to 11.2 months when SG was combined with pembrolizumab. More antibody-drug conjugates, more combinations are upcoming, and I would like to maybe highlight a couple of combinations with immune checkpoint inhibitors and immunotherapy, the Begonia, which is basically Dato-Durva, and Morpheus, sacituzumab govitecan plus atezolizumab. Two key comments here. These trials enroll patients also with PD-L1 negative results, and we can observe very interesting long-term outcomes. Overall response rate in the range of 75 to 80% roughly, and median progression-free survival exceeds this 12 months, which is very interesting and clearly highlights the need to be explored in the next future. Now, again, please answer this challenge question. So, as we have seen, clearly, anti-TROP2 antibody-drug conjugates has changed the way we are going to treat patients with metastatic triple-negative breast cancer, either with pembrolizumab or alone, depending if these tumors do have PD-L1 positivity and patients are candidate to receive immune checkpoint inhibitors. But importantly, how all these positive trials do have implications in the current treatment landscape? Please stay tuned because my colleague, Dr. Huppert, will review this in detail.
Hello, my name is Laura Huppert, and I'm a breast medical oncologist at the University of California, San Francisco. Thank you, Dr. Cortez, for that overview of the efficacy, safety, and design of the phase 3 trials evaluating TROP2-directed antibody-drug conjugates in earlier treatment lines. In the remainder of this session, we will discuss the clinical implications of these findings. So here is my current treatment roadmap for triple-negative metastatic breast cancer, which has changed a lot in the last few months. So I'll highlight some of these changes. So first, when a patient is diagnosed with metastatic triple-negative breast cancer, we want to confirm that with a biopsy and send PD-L1 testing. Previously, we're using chemo-pembro as first line, but based on the data from ASCENT-04, sacituzumab govitecan plus pembrolizumab is now the preferred first-line treatment for patients who have metastatic triple-negative breast cancer who are PD-L1 positive. If a patient is PD-L1 negative, we want to also check their germline BRCA status. If they're germline BRCA wild type, sacituzumab govitecan or Dato-DXd are both preferred first-line treatment options per the NCCN guidelines for patients with metastatic triple-negative PD-L1 negative metastatic breast cancer. If a patient is germline BRCA mutant, the option for a PARP inhibitor is still considered preferred per the NCCN guidelines. In the second plus line, we have various different options, including T-DXd if a patient is considered HER2 low per DESTINY-Breast04, chemotherapy options, PARP inhibitors if not previously used, or there are sometimes biomarker-driven options, although these are less common in metastatic triple-negative breast cancer. Here's my roadmap for hormone receptor positive HER2 negative metastatic breast cancer. In these patients, we try to start with endocrine therapy first, in all cases except when there's true visceral crisis. Usually we start with an AI and a CDK4/6 inhibitor, or fulvestrant is sometimes used if they were recently on an AI, or the Inavo-120 combination can be used if they also were on a recent endocrine therapy with a PIK3CA mutation status that's positive. In the second line, we typically use mutation-driven selection. So if they have an ESR1 mutation, elacestrant and imlunestrant. If they have PIK3CA, AKT, or PTEN mutation, fulvestrant, capivasertib. There are other options like fulvestrant everolimus or fulvestrant CDK4 switch if they don't have a mutation, or a PARP inhibitor if they have germline BRCA or somatic BRCA or PALB2 mutations. After a patient is considered resistant to endocrine therapy, that's when we move towards chemotherapy selections. And typically we're choosing between capecitabine or T-DXd in the first line setting based on the DB06 data. In the second line, we have the option of T-DXd if not previously used, or the option of sacituzumab govitecan per TROPiCS-02 or Dato-DXd per TROPION-Breast01, as well as chemotherapy. And in the third line plus, of any of the ADCs that were not previously used or chemotherapies can be utilized. So do these ADC trials reflect real-world practice? I think some of the strengths of these trials are that they were clinically relevant first-line populations. They included populations that were both PD-L1 positive and PD-L1 negative. Many of these patients had visceral disease similar to our current patients that we see in clinic with this aggressive disease biology. The focus on the first line reflects real-world need as well. Unfortunately, some patients with metastatic triple-negative breast cancer never go on to receive second-line treatment. So moving our most effective therapies forward is really important. Some limitations of these trials include that the trial populations were highly selected, mostly patients with good performance status. So for example, some of our patients with more comorbidities who are older with worse performance status would not have been eligible. This could have underestimated the comorbidity burden given this. The incidence of patients with prior immunotherapy was low. In the United States, for example, we use a lot of pembrolizumab in combination with chemotherapy in early stage triple-negative breast cancer per Keynote 522, whereas at the time of these trials, that was less commonly utilized. And so there are fewer patients with prior IO in the early stage triple-negative breast cancer setting. And few patients in these trials had brain metastases, although those with stable brain mets were allowed. The proportion was small. And now please answer this challenge question. With TROP2 directed ADCs now being introduced earlier in the treatment pathway, clinicians will increasingly face questions around treatment sequencing, particularly as resistance mechanisms emerge during metastatic disease. This diagram shows possible mechanisms of resistance to ADCs. So as you can see on the left, in the wild-type situation, sacituzumab govitecan is binding to the TROP2 extracellular domain, being internalized into the cell and causing cancer cell death. However, there can be resistance to the payload, the chemotherapy part that's attached to the ADC, where once it's inside the cell, it can no longer be effective if there is resistance to that particular part of the molecule. Alternatively, there can be resistance to the target, where if there's a TROP2 mutation, the ADC cannot even be internalized in the first place. In a single patient, there can actually be mechanisms of resistance to both, either the payload or the target, and it's hard in clinical practice to know which is the primary driver of resistance for any particular patient or any particular population of cancer cells. And so what do we need to do clinically to, act on this? So one concern is that there can be cross-resistance to ADCs that have similar payloads. And right now, all three of our approved ADCs for hormone receptor positive and triple negative breast cancer all have topo-1 inhibitor payloads. And so it's possible that if a patient has seen one of these ADCs, that the next ADC that they see might not be as effective if there is cross-resistance to the payload in particular. So most of our data looking at the sequential use of ADCs at this point is retrospective. Here's one example of a study that I led with 5 other centers looking at the use of SG followed by T-DXd or vice versa. As you can see in patients that received SG first, for example, on the top row, in general, they had a longer time on their first ADC and a shorter time on their second ADC. Although there were exceptions, there were examples of patients that had shorter time on their first ADC and longer on their second. And that was also true in the opposite order. If they got T-DXd first, they tended to have a longer time of response on their first ADC and a shorter time on their second ADC, SG in this case, which does suggest that there might be cross-resistance between these ADCs that's leading to the shortened duration of response on their second ADC. Some people suggest perhaps putting a chemotherapy in the middle as a chemotherapy sandwich may resensitize the cells if they do develop this resistance to the payload. And so that's a strategy that's sometimes utilized, although we don't know for sure if that's the right strategy. You can see that it was done here in some of these patients. We do need more prospective data to help us better understand ADC sequencing, and luckily there are some ongoing studies that will help inform our practice. For example, TRADE-DXd is a study looking at Dato-DXd or T-DXd in sequentially used in either order in patients with hormone receptor positive or metastatic triple negative breast cancer. Ceres is a phase 2 trial that's looking at SG followed by after patient progresses on T-DXd. And finally, I'm leading a study through the TBCRC called ENCORE, which is a prospective registry of sequential ADCs in HER2-negative metastatic breast cancer. All of these studies will collect blood and tissue to try to understand the biomarkers, which will hopefully help us better understand mechanisms of resistance and how to optimally sequence ADCs in the future. And now, please answer this challenge question. Finally, here are key ongoing phase 3 trials of TROP2-directed ADCs that may further change practice in the future. The first 3 trials are in early triple-negative breast cancer or hormone receptor-positive breast cancer, because as we know, these agents are very effective in the metastatic setting, and so it's really exciting to think that potentially they can also improve outcomes in the early-stage setting as well. In the metastatic setting, there are also ongoing trials in the first-line setting. So the TROPION-Breast05 trial is looking at Dato-Durva versus chemotherapy plus Pembro in the PD-L1-positive first-line metastatic triple-negative population. And there's also a phase 3 trial with a different ADC called SAC-TMT in combination with Pembro for patients in the first-line metastatic triple-negative setting as well. Thank you so much for watching.
This has been an activity published by Peer Voice.